Hello, everyone. Feel free to move your chairs around because we realize there is an obnoxious pillar right there in the middle of the room there. I'm so glad to introduce to you, I just met, but several of our families know him quite well. Now I'm going to say this, Dr. Hariharan.
Yeah, nice.
Yes.
Good.
Okay. Dr. Hariharan is an orthopedic surgeon at Paley Institute, and he will be presenting today about modern approaches to spine care in AMC. Please join me in welcoming him to the 2024 AMC conference.
All right. Thank you. Thanks everyone for being here. I'm sure it's tough after lunch. But it's such a privilege to be here, and I worked with some amazing folks in learning medicine and orthopedics. I worked with a guy named Paul Sponseller at Hopkins, and then you heard Dr. Nichols speak earlier. I did fellowship with her. Now at the Paley Institute, I work with a guy named David Feldman, and I've learned so much from all of them. And most importantly, I've learned a lot from my patients and the families I take care of in West Palm Beach, and just thrilled to be here and see it all live in action. So, I think, I'm talking today about spinal care in AMC, and it's such an important and big part of taking care of the child or even an adult with AMC, but it's not the only thing. And I really want to focus on, the holistic care, but spinal care is my main passion in orthopedics. No relevant disclosures, and I'd be remiss to not mention Dr. Feldman here, pictured here. A lot of people in the AMC world know him, and of course this on the right is the DuPont Institute, now called Nemours Children's Hospital in Delaware, and all their decades of experience really can't be understated, and what they say, there's no teacher quite like experience. So again, although I'm here speaking about spine, one of the main themes of my talk the entire time will be to emphasize the importance of comprehensive care. And we know that scoliosis is common. It can affect up to 50% of patients, sometimes more. And it can present in various forms and various severities, but every child and every patient should be examined at every single visit. It doesn't have to be with x-rays, but it has to be a part of the comprehensive examination. And another main point here is routine follow-up is critical. So we know that AMC itself is not a progressive condition, but as a child grows and muscle forces change and bone lengths change, the contracting forces are pretty powerful and things can change quickly. So this patient is now a young adult, but he had surgery as a young child in the Midwest somewhere, and it looks like a well-done procedure and probably did wonders for him at the time, but he's been lost to follow-up, and at 25 years of age, this is his body position, and that's no way to functionally live. I really enjoy technology. Okay, it's one of my main passions, and I asked ChatGPT to make a representative image for my talk of a child with arthrogryposis. And even if you ignore the spelling mistakes, you can see it did a pretty good job, right? It shows you multiple joints. It shows that there's something about contractures, but it missed the spine. There's nothing in here about the spine. So, my key takeaway, if you don't listen to anything else, is the whole patient has to be treated, not just the spine and not just the extremities. And you have to have children. I take care of children. I'm a pediatric orthopedic surgeon, but you have to let the child have a childhood, right? So the main management goal is about independence, and there's always a large focus on ambulation, but we've studied this long-term in adults with various forms of disabilities and conditions, and really ambulation is the fourth most important thing on the survey. So number one was communication skills, number two was activities of daily living, three was mobility, and then walking. So we really have to keep all of this in mind and understand that a child still has to be a child, and yearly and repetitive surgeries are not the way to go. So this is an example of a girl, 11-year-old from outside the country. We get a lot of patients from around the world, and we initially met her on virtually, and she's been treated her entire life with numerous surgeries of her lower extremities, and the spine has just been always ignored. And because we take care of so many spine patients, she Zoomed with us and we said, okay, this looks like an operative curve. Obviously, you can't operate on someone over Zoom, so we asked her to come in for an exam. And when you examine her, she has no range of motion of her hips, despite all those surgeries. And you can see she actually bends through her spine to sit upright. So that's where this kyphosis comes from. This is the only way she can sit upright. So could I do the spinal fusion here and make her spine totally straight and her pelvis totally level? Easily. But if I did that, I would do her a huge disservice. So, we got her to the operating room. Maybe it was contractures because she was tight, but even asleep under anesthesia, there was just no motion. So we canceled the surgery, worked on her hips, and then ended up doing her spine later on. So, I give ChatGPT another chance. I said, okay, you messed up the first time. Make a graphic about, my key takeaway points. And, I got part of it right. It says treat the whole patient. But, the best part of it is it was able to, make fun of itself and said, don't be like ChatGPT. So that's a good lesson for me and for all the providers you see that, don't be like ChatGPT, treat the whole patient. So what is scoliosis? It's really a three-dimensional deformity. It's not just sideways curvature. It bends sideways, but it can also bend into the chest and rotate on itself. So it's more than just what the X-ray captures on a single plane film. And there's lots of different types. So you can have syndromic scoliosis, you can have congenital scoliosis, you can have idiopathic scoliosis, and there's a couple of other forms too. But the most common one we see and hear about in news and Instagram is idiopathic scoliosis. This is the one where there's no underlying genetic condition or syndrome. Usually presents in teenagers or young 10 to 12-year-olds. And sometimes there's a genetic component, but there's really not anything else underlying, and they don't have pain or other symptoms. Then you can have congenital scoliosis. This is something a child is born with. It can be because of manufacturing issues. So they can be either the spine didn't completely segment into a rectangle or it fused to the adjacent one, causing a curvature. And these cases is where you can have additional organ malfunctions because the spine forms at the same time as your other vital organs like the heart and kidneys. So again, a comprehensive evaluation is key. And of course, we'll focus today on the neuromuscular causes of scoliosis. So this is the one that's associated with abnormalities in the nerves or muscles or bones. And arthrogryposis is a big example of neuromuscular scoliosis. So how do you work it up? The exam is key, and then you move on to imaging. And getting a full body X-ray is super important because, again, it's not just the spine we're worried about or just the legs. And this is called an EOS machine. I have no, relevant relationship with them or anything, but this is a slot scanner. It's super low radiation. It allows the child to stand or even sit in there, and it gives you a big full picture of the entire body, and the radiation levels are incredibly low. And the second thing is an MRI. From a treatment standpoint, this is one big thing I want you to take away from today. So, we've always had a suspicion of something known as a tethered cord in children with arthrogryposis. But this is the first time we've actually studied it, and we're presenting it at our big Scoliosis Research Society meeting. So what is a tethered cord? In the uterus, the spinal cord extends all the way down to the bottom of the spinal canal, and as the embryo and fetus grow, it moves up the spinal canal, and usually the spinal cord should end around L1, maybe L2. But we've noticed in children with AMC that it ends much lower. It's usually attached by a tether or a rubber band. And, historically, this has been associated with developmental delays, difficulties with bowel bladder issues, and toe walking. So, our first step was to study how often this actually happens, and compared to the quote-unquote normal population, in the AMC population, the spinal cord ends at much lower levels. So what the implications of this from a clinical standpoint remain to be studied, but this is an important takeaway from the care of the spinal care of children with AMC, and we get an MRI on everybody now. You can get additional imaging like a CT scan, but this involves radiation, and we know children with various conditions end up getting more radiation than the child who doesn't. So we really try to minimize it, and other studies like an echocardiogram or lung studies can be super important. So I'll get into some of the treatments, and we'll work our way up on the invasiveness or the involvement of it. So first steps first is observation plus minus bracing. And I'll use case examples to go over all of them, and you can ask me questions at the end if any occur. So this is a young boy from California. He has pretty involved arthrogryposis. He was less than a year old when we first saw him, and his entire body was involved, and all he really did was be bedbound and laid supine. And, you know, on an initial x-ray here, we can see that the spine certainly looks ominous, right? His pelvis is tilted. He has an obvious scoliosis, but the key is to work slowly through the child and not just jump to what's most obvious on x-ray. So we got him into our excellent physical therapists. They did wonders in just a matter of months, and he was sitting upright. You can see his knees bending, and he still has the pelvic obliquity and scoliosis, but this is a night and day difference. And then he got an MRI, and lo and behold, he had a tethered cord. This was released by our neurosurgeon, and he continued physical therapy. You can see he's sitting way better, and you can see little signs of a cast here that he's getting for his knees and his club foot. But he still has scoliosis, but he's sitting in a way, and his body's positioned in a way that we can actually get him into a brace that's comfortable. So here he is in a brace. And while undergoing brace treatment for his spine, he had his legs worked on with his hips and knees by Dr. Feldman. And although, you know, initially one of the most striking problems you could see on x-ray was his spine, here he is, you know, just a year, maybe a year and a half later, with spine doesn't really look to be like such a big deal anymore. Of course, we're going to keep an eye on it, but this is a big difference. So the next step will be growth-friendly maneuvers, and I put it in quotes because we're not entirely sure how friendly it is. It's better than a fusion, but we can speak more in detail about that if anyone has questions. But this is a girl with Escobar syndrome. In this picture here, she's about 2 years old. Again, you know, you can see the presence of a trach, and she has a reasonable amount of scoliosis, and her pelvis is not so stable, so it makes it difficult to sit. She's from another state, but she was trialed with a brace, which did a pretty good job. But out of the brace, you can see that the curve is pretty progressive, and now she even has a G-tube for her feeding. She was tried even on a different brace, and as soon as the brace comes off, her spine doesn't tolerate it so well. And this is something called a traction x-ray, so this gives us an idea when we're considering surgery on how much of a correction you can expect to get. So my hands are pulling under the armpit, and the mom's hands are pulling on the pelvis, and it shows us, you know, in the middle section there's a bunch of fusions, so that's not moving so much, but the rest of the spine and the pelvis are pretty flexible. So this means we don't have to worry about traction, which I'll show you later, but you can take a child with a pretty severe scoliosis and pelvic obliquity and make the pelvis level and correct the curve. So she still obviously has a scoliosis. You can't get rid of the whole thing with growing techniques, and especially when you have a fusion of so many segments, but her head is more centered, she's sitting more upright. And every 3 months she comes to the office, and we put a magnet on her back. If you've seen them, they work to engage these rods, which have magnets built into them, and every 3 months her spine grows about 3 to 4 millimeters. And you know, as you see this, you can really see the growth through the rods here compared to where you first start over here. So this is super important for her. She's walking more, she's sitting upright more, she's speaking more, her potty training has gotten better, and she's just more interactive with the world. And she had a tethered cord release as a young child, which was discovered. So the theme continues. So here's another growth-friendly option. This patient was so small that the magnetic rods would not work just because of the ability to cover her incision over the rods. So she has arthrogryposis and congenital fusions of lots of segments of her spine. So this is in the upper thoracic, this is the main mid-thoracic, and even in the lower portion. You guessed it, she also had a tethered cord, which is released. So at the same time as this, we put her into a halo, which is a ring around the head. And that helps to slowly pull her spine out to length, because her curve was not so flexible because she had so many congenital segments. So you can see here serial x-rays with her in the halo, the curve slowly gets better and better. In the middle where the fused segments are, you can't expect it to move. You can only move things that are movable. So our main goal here was to get her head centered over her pelvis. And here she is in the halo. The family gave me permission to show this, but she's completely unaffected. She's wearing her silk pajamas. She's got her bejeweled crown, and she enjoyed life for the 3 weeks in the hospital. And we got her from what she started with this to this. So a couple of differences to note here. She doesn't have the magnetic rod because her skin wouldn't fit it. She weighs less than 20 pounds. She had rib to pelvis instrumentation here because you can imagine if so many segments of her spine are already fused, and I fused the 2 remaining ones that are growing, I'm not really helping her lung growth or her spine growth. And then the main culprit here that caused all of the scoliosis was the middle segment where it was fused. So I completed the fusion on one side so that it doesn't continue curving as she grows. And you can see here, I didn't just forget to put the rods in. I put these screws in for preparation for putting in the rod on this side when she comes back in 4 to 6 months after the plastic surgeon helps to expand her skin, so we can put the same concept on this side to help the ribs and the lung grow on this side. So now that in the older child, you don't have to worry about growth. So we can talk about posterior spinal fusion. So this patient has scoliosis, which is pretty obvious, but it doesn't look so bad, right, compared to the other ones I showed you. But what's important to note here is the amount of lordosis in her thoracic spine. So the thoracic spine is actually supposed to stick outward like this, okay? But hers sinks into her chest. And we followed her lung function tests over the years, and as she grows and it keeps sinking into the chest, it actually affects how much breathing you can take. And this is called restrictive lung disease. So she had a fusion surgery where it wasn't so much to correct the scoliosis, which did happen, but to pull the spine out of the chest. And you can see the volume in the spine actually looks more kyphotic here as opposed to previous. So again, if you compare the difference, the spine really ends here and the lung goes here. Where, as opposed to here, you can see much more of the lung contour and the volume for her lungs. And then when the curve is stiff and severe, even with a posterior spinal fusion, sometimes you have to do halo gravity traction. So this is a 13-year-old boy. He's a Jehovah's Witness, and he had the spine unfortunately neglected for many years, both based on parent fear and his Jehovah's Witness status. They were worried about the blood transfusion needs. And he doesn't have any fusions. He just has a typical scoliosis, but it's high and pretty rigid and severe. And he also had a tethered cord, which was totally missed for many, many years. So same thing for him. He had a tethered cord release the same time that we put the halo on. And he was in the halo for about 4 weeks. And you can see it made a reasonable difference, not completely like in the young girl I showed you. And he underwent a fusion surgery. So, technology is really important here. So he's 13. He has a rigid, big curve. He's a Jehovah's Witness. So doing spine surgery in a child is relatively risky enough, but doing it in a big curve in a Jehovah's Witness takes a lot of extra attention and a lot more sleepless nights on our end. But we use Cell Saver, we use navigation systems, and he's done really well so far, knock on wood. And then this is more of a controversial subject, or lesser done, but this is called vertebral body tethering. So this is FDA guidelines say this is reserved for children with idiopathic scoliosis with growth remaining. But in certain cases, we feel that it's important to offer this for our families and come up with a shared decision making. So the way these implants work is you go through the side rather than the back. You put the screws in, and instead of a rod, there's a rope or a tether that connects the screws together, which not only straightens the spine, but allows some flexibility, which obviously rods and screws cannot. So in this patient, he has severe hip contractures, and his curve is in the lumbar spine. So he really relies on the lumbar spine to bend and sit and move. So could this be fixed with a fusion? For sure. Could this be observed for now? For sure. But he has significant growth remaining, and we know that this curve is going to get worse. So he had a tether surgery done, which allows him to keep all of his motion and take advantage of the amount of growth remaining to slowly correct the spine. It's like if you've heard of 8 plates or growth modulation for your knees, same idea, but for the spine. We just don't have long-term data on this like a fusion, so we're not entirely sure, especially in the non-idiopathic world, how effective it is or how long it'll last, but these are open conversations you got to have with the families, and they're super well informed and decided this was the best for their son, and he's a couple years out now and is doing well. So, I just want to end again by saying that you have to consider the whole child. It's very easy for me to be a spine surgeon and say every spine needs to be fixed, but that's just truly not the case. And there's more than one correct solution. So I'm telling you about all these options. There may be another surgeon who comes in here and says this is blasphemy. I would never do rib to pelvis. I would do spine to spine or rib to rib, whatever. But the key here is to keep the treatment principles in mind. You want the child to be able to function and sit and speak and not have the spine get in the way of growth and lung function. And then you really have to be an advocate for yourself and your child. We've done research on this, and we believe in various things like the tethered cord being more prevalent, and we've proven it scientifically, but that all these things takes time to adapt, and this is why meetings like this are so important to improve knowledge base, not just amongst yourself or from me to you, but from you to me as well. So, I'm really thankful to be part of this community and taking care of a lot of patients with AMC. And one of my favorite books is Outliers by Malcolm Gladwell. And he says the values of the world we inhabit and the people we surround ourselves have a profound effect on who we are. And not that old, but I can tell you that's true for sure. So my contact info is here. We have an amazing team, and the community that takes care of these patients is small, and we all work together. And we're just here for you. And thanks for having me.